Good morning. It's lovely to be here. My name is Tamara Simon, and I'm a pediatric hospitalist at Seattle Children's. And the topic of my talk today is coping with hospital stays. I'm hoping this will be a very interactive session, so please feel free to pipe up and offer suggestions along the way. I wanted to start by explaining that I have no financial interests to disclose. And walk you through what I was hoping we might accomplish today in terms of learning objectives. So I'm hoping that those of us who are here in the room and perhaps online will be able to identify some challenges associated with hospital stays. I want to also speak to some very cool information that I read in preparing for this talk that touches on some different models of patient and family experiences. And basically have you guys have the opportunity to think about what stage you and or your family might be at in this particular model. This same paper that I'm going to allude to also talks about types of family and system interactions. And again, I thought this might offer an opportunity for you all to think about where you and your family might be at in that model. I also wanted to sort of start to encourage you to think about the resource availability that's offered by hospital stays and identify some strategies to overcome challenges that are associated with hospital stays. So again, I'm hoping for as interactive a session as possible and look forward to your thoughts. But I thought I'd start by telling you a little bit about me and what has informed my perspective. So I'm a pediatric hospitalist. So what that means is I've completed general training in pediatrics. I am a pediatrician. But rather than focus on the outpatient setting, I have really focused my career on taking care of children in the hospital. So I have been in practice for 12 years. 2 of those years were in Denver, Colorado, at Children's Hospital, as well as at some community hospitals. I then went on to spend 4 years in Salt Lake City at Primary Children's Hospital. And for the past 6 years, I have been in Seattle at Seattle Children's Hospital. And I first worked as a surgical hospitalist for about 2 years, so in very close collaboration with our neurosurgeons. And then I transitioned over to my personal professional passion, which is the inpatient care of children with medical complexity. And at Seattle Children's, for a long time, we had what's termed the medically complex child service. So that's sort of where I have been professionally in terms of my clinical practice. I also have a pretty robust research focus, so I spend about 20% of my time in clinical practice and about 80% on research. My research focus has been primarily in the field of hydrocephalus, but I have a larger interest in this general category of children with medical complexity. And then I've also had the privilege of some national leadership roles in what is this emerging field of pediatric hospital medicine. So I sit on an editorial board for our journal, Hospital Pediatrics. I've organized our national meetings, so I have some familiarity with some of the movements that are sort of afoot nationally in primarily children's hospitals. The other thing I wanted to point out to you about myself that probably means I have a bias is that all these places that I've worked have sort of been either tertiary or quaternary care hospitals. So these are basically hospitals that serve large sort of catchment areas, but tend to see the most sick children. So I end up sort of having a real bias of the most involved. So I fully recognize that and just sort of want to state that bias up front. So that's a little bit about me. And I wanted to share with you a little bit about what I've observed of children and their parents, and then a little bit about the hospital system before I turn the microphones over to you guys. So one thing that I've sort of observed of children, and I know this is sort of gross generalizations, and it may not apply to you and your child, but on the whole, sort of taking care of hundreds if not thousands of families over 12 years, I've generally observed that kids themselves seem to kind of adapt pretty well. I mean, as they get older and sort of develop more expectations about what their hospital stay and or their life can look like, i.e. the teenage years, things can get a little bit more challenging. But I found on the whole that kids tend to be pretty resilient. I also have come to believe that they benefit from being told about what's happening. I know it's sometimes hard to have very difficult conversations with children, even when they're young, but I think that, and on the whole, I think kids do better with understanding in an age-appropriate level, like what's happening to them and their body. And in preparation for this talk, I actually went and did a literature search in the medical literature to try and understand what we have scientifically or from a research capacity understand. I was a little bit surprised at how little has been done, at least in the medical literature. There's been more in the nursing literature. And what I did find sort of suggests that, surprisingly, when researchers go and talk with kids about their experience with hospital stays, they actually kind of, in general, have a kind of a good time, because, and it sort of makes sense if you think about it, they sort of have their parents' attention, a lot of it, and some extra time. I guess they significantly, notably called out their leisure activities. So this is kind of not what I was expecting to find, but for me it sort of reinforced this general impression that I have that kids can roll with punches. Again, not everybody, but on the whole. And I'll be interested to hear if you guys feel differently. So a little bit about what I've observed of caregivers. So, and by caregivers, I can mean parents, biological or non-biological, step-parents, grandparents. Caregivers is sort of the general all-encompassing term. So I've observed that adults can often have a little bit of a harder time adapting. So again, depending on their expectations and their hopes and dreams and how those might not be being met. Like children, all of us benefit from being told what is happening. So, and then I again went to the literature to sort of understand what parents sort of need to know when they're taking care of seriously ill children, or sort of what their priorities are. And I thought this was a paper done by my colleague at CHOP that I thought, Chris Feutner, who I thought was pretty, a pretty accurate representation of what I had experienced. So it turns out that when this has been studied, parental priorities for seriously ill children, so these are children who are in the ICU, are making sure that their child feels loved, which is probably a general parenting priority, focusing on the children's health, making informed medical decisions, and then advocating for their child with medical staff. So that for me really resonated again with sort of my own personal clinical experience. So. And then there's a bit about what I've observed of hospital stays. So I'll be honest with you, I think hospitals are scary places, even though I spend my life in them. I feel like there's a lot of opportunity, especially the more complex a child is, for the handoff between a parent and family and hospital staff to not go well. So times of admission and times of discharge are sort of rife with issues with lots of medication errors. For many of the children that I take care of who do not feed by mouth, there's a lot of opportunity for dietary or formula kind of errors. And then there's all the things that our parents and families do to maintain health at home that can fall through the cracks when it's being transferred sort of to the care of the hospital. So I've really been interested in efforts, and I'm not alone. I think our field of pediatric hospital medicine has tended to focus on safety issues and recognizing that hospitals, although we'd like to think they're good places, can be safer or should be safer. So the other piece that's really critical is in my estimation from a 30,000-foot view is communication. So I think there's a lot of communication between the child and caregiver, caregiver and the medical team, and then there's all kinds of interesting sort of nursing team structure, medical team structure, and then you've got all these other ancillary services like therapies, nutritionists, dietitians, other resources. So there's all kinds of people coming in and out of your room when you're staying in the hospital, and I think it can be really hard to understand what all those providers' roles are, how they play into their team structure, and there's so many opportunities for communication to sort of fall apart. So one of the efforts that's really been pushed nationally, and I don't know if you all have experienced this, is family-centered rounds, which is sort of an opportunity for the family and typically the medical team, ideally with nursing and potentially even other ancillary staff, to all come together. There are some real, from my vantage point, wonderful opportunities that family-centered rounds present. There's also real opportunities for families to feel uncomfortable or for sort of complexities to be introduced. So if anyone's experienced that, I'd be curious to have your feedback. So, And then also, I think the way we do things in hospitals are not necessarily totally intuitive, so I think it can be really important for caregivers trying to navigate through hospital stays to sort of understand the process in our hospital. So those are sort of some of what I've observed about hospital stays. And then I was hoping to sort of turn the tables over to you guys and hear a little bit about what you guys have experienced in terms, for you or your family has experienced in terms of challenges of hospital stays. So does anyone want to offer up? Yes, Dawn.
So I have 2 children, and so if one child has a hospital stay, I have to figure out what to do with the other child.
Okay, and so to repeat that for those of you who are streaming, oh, wonderful. Dawn has 2 children, and when one of her children comes into the hospital, she has the dilemma of childcare, so for her other kid. So all right, so can I, in a more general sense, sort of talk about, so there's childcare, but there's also just sort of maintaining the home front? Would that be fair to say? Okay. Maintaining the home front. So I put childcare as a bullet under there in case other folks have other ideas. So, anyone else? Any other challenges?
I have one more challenge.
Okay.
I don't think this is actually on, but
Oh,
I will.
there you
Oh,
are.
it is on. Okay. So when you go to the hospital, they take care of the child, but they're not there to take care of you. And I know there was one time in particular where we went in. My child had a lot of diarrhea and vomiting, just had a bad stomach bug, and so and so the urgent cares were closed. I thought I was going to go in and get a little bit of tummy medicine, maybe get some IV fluid.
Yeah, they decided to stay.
Then they just said that you're going to stay. And so then from my vantage point, I thought, okay, I need contact lens solution. I need contact lens, I need the contact lens case. I have epilepsy. And so it's like, oh, I have to have my epilepsy drugs.
Yeah.
And they're not here. And so it's like I can't really leave my child, but then at the same time, I have my own set of medical needs
Sure.
that are now not going to be met.
Okay, that's a great, okay, so self-care needs, which are probably even more exaggerated if it's a totally emergent sort of admission that you weren't anticipating. So especially for emergent stay. Okie doke. Yes. Can we hand him the?
I could probably yell out.
We want our
Okay.
online
All right, there we go.
audience
How
to
are you? One of the things that I think as far as a challenge for a family, and we experienced that with my granddaughter, was when she went to the PQ and she was hooked up to all of these machines
Absolutely
and a 24-hour nurse and as such, understanding what's going on.
Yeah.
Because as a parent, you're sitting there, or a grandparent, you're sitting and you're wondering, well, what's going on? And if you don't ask questions, and so I'm going to say challenge, but then strategy with it was
Wonderful.
that we talked about, we don't know what's happening, and a lot of times when the nurses or the doctors are coming in, they're talking amongst themselves, or they may give you a quick synopsis of this is what's going on. In something that they're giving you is the answer that you probably, things are going okay, everything's fine. But yet, for 24 hours, they've been injecting and doing different things.
Yeah.
So one of the things that we did as a strategy, per se, was started journaling. Every time the doctor or the nurse came in and did something,
like it.
my daughter kept a journal. And she said, well, what exactly are you giving her? Well, we're giving her medication. Well, what is it? And how much are you giving her? So not only that they had their own medical, but she was keeping track. And then because if the nurse was walking out, she was monitoring what was happening to our granddaughter and her daughter. So she also made notes as to what was happening. And so she continued that also when my granddaughter went home, which helped her when she was able to talk to her doctor and go back and say, and speak on the same level. It's not like, well, she's doing okay.
Yeah.
And
that's a fantastic.
And being able to understand the terms.
Yeah.
So I think that's a challenge for a lot of families because you don't know what's happening to your child, and so how do you deal with that?
Yeah.
And how do you help the families do that?
I think it's a wonderful example of sort of what I've certainly seen, and then a wonderful strategy to sort of overcome it. So thank you for sharing. We will come back to this and revisit this. So I'm going to use your example.
So, hi, I have
Hi.
one. When it comes to a special needs child that's severely special needs,
Yes.
I know personally I've come across, because my identical twin sister is profoundly disabled due to hydrocephalus. A lot of hospitals don't necessarily, and maybe it's just a training aspect, it's very possible, a lot of hospitals don't have that necessarily, their staff is fully equipped and able to handle the complex special needs child. And then when the family comes in and there's, a caregiver that's with them 24 hours a day, they kind of take that step back and go, okay, yep, you're in the room, don't worry about it, it's all well and good, and they don't realize. So it's a big challenge, because when you're there, but yet if you want to go, say, down the street to a Starbucks, for example, get a coffee, and you have to leave that special needs individual, that patient, you have that question of, are they really doing their jobs and are they equipped, because they don't know. But yet then you go back, when you try to explain their special needs, sometimes you get, okay, great, that's fine, and it's in the chart, or really. So it's a big challenge if you think about with special needs families.
Yeah, and I don't know that I'm going to do it justice in a bullet. But what I heard a little bit of was like staff comfort level.
Yes.
And can you, it sounds like you might be thinking of a kind of a specific example. Can you paint a picture for me of like sort of what kind of hospital is this? So the reason that I'm asking this is that, and I alluded to this earlier, like I have focused my career in tertiary care hospitals. So like your Seattle Children's, your Denver Children's, and again, as I sort of alluded to, this is a place where our most complex children sort of aggregate. So for us in Seattle, it's actually over a 5-state area. And we, in the hospital medicine business, sort of call other hospitals that are out in the community setting that are often serving adults and kids, and more typically healthy kids, community hospitals.
See, like in Connecticut, where I'm from, there is a children's hospital, but once the children, and even a special needs child, is 18, then they're going to the, I say, quote, adult hospital. So there's that transition.
Okay. So I'm gonna sort of say, so there's a staff comfort that is specific, in your example, to adult hospitals.
And that transition too, because they look at it as, okay, now the individual's no longer a child, but yet when you bring up the children's aspect, there's
that's a really big problem. And I am, similar to your points, I have some thoughts about that, so we'll definitely revisit it. And that's for me, that issue of transition to sort of 18 is a huge sort of policy ball wax that I'm not even going to pretend to have the solutions to, but we'll certainly touch on. So, okay, so staff comfort level, and this is sort of specific to the adult hospital setting. And there's a little bit of what I heard about, it's not a burden because it's what our jobs are as parents, but sort of the unique expertise that a family develops about that particular child that pretty much everyone on the care team comes to sort of rely on, that can be a lot of responsibility. Is that?
Yes, absolutely.
Okay, so it can maybe something about unique expertise.
Yeah.
It's not really necessarily a challenge, but it's a theme. It might kind of be isolating. Okay, and this is really super helpful. It has helps me really think about what I want to comment on. Any other thoughts or challenges? Dawn's coming back with more.
Just one more.
Yeah.
My other one is if you have a hospital stay and another child in a room over or even a bed over becomes seriously ill.
Yes. So you kind of had this experience that you shared with me of a code happening. So I imagine in the PICU. Well, go get pants here.
We experienced that also, and this was probably 2 weeks into our stay in PQ, and still not knowing with our own grandchild.
Yeah.
And there was a child that was 2 rooms over who coded, and it's very difficult. And I think what was the biggest thing is that the support from they kind of close everything off in your room and try to make it as peaceful for the family. But as you're sitting there still wondering, it could have been our family. And so I think one of the biggest things is how does the staff continue normally?
Yeah.
And still, because they're in one room and then they're coming right over to your room. And,
Yeah. Yeah.
And
So, and I know that Dawn had mentioned to me, her experience was in a teaching hospital, and so and there's this phenomenon of a giant herd sort of descending. So your example was sort of at 2 a.m, like the entire hospital showed up in a room a couple of doors down or something. So there's sort of the immediate trauma, and then there's the how do you talk about that with your kid? And I heard a little bit about, so there's sort of with your child, and then there's a little bit about sort of what impact that has on staff that I heard you talking about. So did you feel like the staff was overwhelmed with that, what was going on? Or
at the time that it happened, yes, and felt worse for the family because the family had been there with the child,
Yeah.
and they weren't there at that point. So it was all the health care there, and so when the family arrived, it was devastating for some of us other families that were there because you want to reach out but you can't.
Yeah.
And
Yeah.
that
And
the
that-
staff carried on as
Yeah.
if everything's okay with our child, but still
Right.
it hits home regardless of who.
That's a really interesting point. I recently had a very unique experience of my neighbor's child being hospitalized, and my neighbor is an ICU nurse in the adult setting, and her husband is a bus maintenance guy, and their son has a chronic condition and was hospitalized and actually onto my medical team. I was not on service at the time, but he ended up sort of declining and getting worse and going to the intensive care unit. And so they stayed for, I think it ended up being 3 weeks in the hospital, and I stopped by every night for the 2 weeks that I was on service. And I sort of I'd known that this existed, but I don't think I really appreciated it until I was right in the middle of it, is that there's sort of like a family network that happens, and it's sort of very much below, as a physician, my radar, but families get to know one another, and they start to really care about what's going on with each other's kids, and then you have something horrible happen, and everyone knows that it could have been theirs, but also you don't quite know how to, or there's also the fact that there's a little community of parents that are sort of all affected by this, and so yeah, that's a very interesting point. Thank you for reminding me about that. And I don't know. Yeah. Anyway. So okay. All right. Does anyone else have any more challenges they want to put up on that we'll revisit and come back to? All right. I will go ahead and you already started coming up with some solutions or strategies, I guess is the term that I'm using here. So some strategies. And so your example was sort of using journalists that sort of arose out of a complex PICU stay, was journaling that it sounds like continued long outside of the PICU and sort of into your daily, or into your daughter's daily life of caregiving your granddaughter. So are there any other, I know Dawn, you had we had talked a little bit, I'm sorry, I don't mean to call you out, but we talked a little bit about your experience at least for a time of being a single mom and really having to deal with the childcare issues on the home front. So just was curious, and we talked a little bit about what your strategies were. So do you care to share?
Sure. So as far as strategies go, and what we kind of talked about earlier, there are people that are capable of being a good child care person, and then there are people that are willing. And sometimes they're in the same boat, and that's a wonderful thing. And then other times you have people that really want to help, but for one reason or another, they're probably not the best choice. And so it's trying to find those people that are both willing and that are able.
Yeah, exactly. And we had talked a little bit about sort of the social network. So you and I imagine it's, and I already alluded to with my example of my neighbor and the fact that I would stop by the hospital. But you were sort of talking about your social network when you were a single mom, of being like, was it your mom and whatnot. So I think there's at least part of the strategy is a social network, with the caveat that you have to have sort of a stand-in replacement caregiver who's not only willing but also able. and that can be a tricky combination.
And then you also have to consider the geographical proximity as well, because you might have somebody that would be great, but they're not going to be able to drop on a moment's notice, and they're not going to be able to be there within an hour.
That's a good point.
So I found it was helpful to have a neighbor a few doors down that was willing and able to have a child dropped off at 2 a.m. And then also, then to have a long-term solution, a few hours later.
Okay. So I'm going to say standing caregivers who are willing, able, and available,
Yes.
which is sort of a holy grail, isn't it? Is that reasonable?
You said there the Holy Grail. I think that kind of sums it up.
Right, exactly. Easier said than done. So, all right. I'm going to come back. So you were also brought up this idea of like sort of self-care, and you had your example of going in. I can imagine with any kid with hydrocephalus or with a shunt who comes in with vomiting and diarrhea, doesn't get treated like they necessarily just have acute gastroenteritis. People start to get worried about a shunt and often want to keep the kid overnight. And you had this example of needing your medications and whatnot. So I'm curious, in that instance, did you? My gut was you were probably relying on your social network, or is that not the case?
No, we can jump down there.
So talking about self-care as well, and you said an emergent stay, and that's kind of what it was for me. We took the kid in and thought that it was going to be really quick, just there with a stomach bug. And then while we were there, we're like, you know what? We've been dehydrated. We've got some shunt drainage going on. We need him to stay. Yeah. And it was something completely unprepared for. And so here it is. You have 2 kids in the hospital, and really one kid isn't supposed to spend the night. So then first of all, it's to get somebody to come and pick up the other child. But then I had my own medical needs as well. Right. Because I have epilepsy. I have to be on medication every day. And at the time, I had contact lenses, and so I was sitting there thinking, well, how am I going to deal with my contacts? How am I going to deal with my medication? How am I going to deal with all those things that I normally am totally able to deal with when I'm at home? And so I kind of had to calm down and just kind of use the noodle and think creatively. And I went and was looking through the hospital services, and I found out they had an outpatient pharmacy. Ooh. And then when I heard that, I was like, ding, 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 outpatient pharmacy. Okay. So then I was actually able to call the pharmacy where my medicine was at, have them transfer the prescription to the outpatient pharmacy, and then they could do like a partial fill. I had just ordered my medicine, so I didn't want to pay for like another 90-day supply, but I'm like, hey, can I have about a week's worth? And so they did that for me. And
That's really cool.
Yeah,
I had no
that
idea.
was awesome.
Thank you for that. So
and
wonderful.
then as far as contact lenses, I talked to the nurses about it, and they have had that before, and so they actually got me a couple like little Dixie cups. We put some saline in there, and that actually worked out pretty well too.
All right. And I know in our hospital we actually have, you have to start to engage and ask for help, but we have all kinds of people donate toiletries. So there's actually sort of a bin of, and I believe it includes random toiletries such as contact lens solution and whatnot. So I heard you say think creatively, and I had no idea you could get meds at an outpatient pharmacy. So thank you for that tip. Nursing staff helped you out. The other thing I just would bring up in my experience is, I practice in Seattle, and we will have kids come down, and they might show up to their urgent care in Alaska, and the next thing you know, be down here in Seattle. So we can end up with these phenomenally complicated situations with emergent hospital stays. So we often engage our social workers. And I remember unfortunately it took a month, but we had to get a wheelchair down from Alaska for a kid of mine who sort of had his wheelchair left behind. And so anyway, I would encourage you, I think of social workers, when I hear about these things, I kind of turn to my social work colleagues and ask them to intervene. So anyway, I'll put them in as a resource, and we'll come back to this because it sounds like the notion of garnering resources is one we'll revisit. So code status. So how, both of you had sort of these examples of tragic sorts of situations. Yeah.
I did too, but adult code status. She had coded in the middle of the night with one of our caregivers there. And how we were informed is my mom was called and whatnot. And I was brought in by hospital security So in a situation when it comes to code status, I fully understand, but on that, I don't think somebody's needs were met because you're being escorted by security and you're like,
Right.
well, hi,
Right.
hi everybody, it's
Right.
different. So,
Hospital security doesn't cut it. It's
and then
sort of-
when it's done, they all kind of, I call it the wolf pack. They all come at you and talk to you about it. So,
yeah.
I mean, we coped at it because how we devised it is we just sat down as a family and, talked about it and said, this is what it is, and we kind of worked through it that way. So we all kind of sat together as a group and with the doctor and said, this is why it had happened at the time.
Okay. So a strategy is, it's again slightly different, but sort of debriefing with medical staff? Yes. Okay, all right, and a group debrief, it sounds like. Okay, so group debrief with medical, and that was more these were slightly different instances because these were people peripheral, but this was, group debriefing.
I think that's important. I think when it happens, they should, be gentle about it and, kind of just say this is what's going on.
Yeah.
And, have that conversation.
Sure. And then if you're sitting a little bit more on the periphery, like in your two instances, and you have a child who sort of has observed that happen, did you talk with your kids at all about what happened? And if so?
I think the way that I handled it then versus the way that I would have handled it now was different, just because the ages were different. At the time, I'm trying to think how old he was, probably kindergarten age. So not really a lot of understanding.
Sure.
And so, when we heard the code blue, and then you have, I call it the herd of elephants
Right.
that are suddenly going down the hall. I got up, I closed our door to our room so that we wouldn't hear it. And then he's like, what was that? And I'm like, you know what? I think a kid is sick and needs more help, and they're going to go help him.
That sounds great.
And then it was like, once I did that, and then also, it seems like at that age, they're very in tune to the parents. And so it's like,
Thank you for bringing that up.
if I panic, he's going to panic. So I just had to sit there with my little crocodile smile and, he's kind of sick. We'll just stay here and let them help him. So that went down. Well, actually, and then the really sad thing is that the code did not go well. And so afterwards, the parents reacted, which that's probably the same way I would have reacted. But then he hears the mom, screaming and crying and all that. And it was like, then he asked me what that was. And I'm like, it sounds like somebody's upset. Maybe it's a baby crying, which, that was kind of a white lie.
Yeah.
But I just kind of played dumb. And I was like, go back to sleep. I'm sure everything is fine. But I think if at age 5, he really wouldn't have had the capacity to really understand, death at that age, especially death of a child. So it just would be too hard.
Of course. I think that you made a comment that I really want to come back to, which is, and I think I alluded to it a little bit earlier with sort of what the kids experiencing and then what their caregivers are experiencing. And I think you sort of alluded to, what's going on, and you are trying not to panic because you can really quickly imagine yourself in that situation. You feel like you're a heartbeat away from potentially being in that situation yourself. And your child is responding to how you're reacting. So there's sort of, it's sort of the child's experience, and they don't need to know everything that's going on. I think that making them understand that this is how the hospital staff responds when a child's getting sicker and needs help, I think is very age appropriate. And I think that taking care of yourself or checking your own reaction or understanding that your kid is, or the child is reacting to your reaction is important. So I don't know quite how to, anyway. But so I think that, I don't know how to put that. I'll have to think about that a little bit. But did you have, it sounds like you had something to add. Oh, okay. I don't know if the strategy is sort of, at the risk of oversimplifying, like self-care or sort of being attuned to your own reaction versus your kids, or self-awareness maybe. And then the other thing I would bring up is, I wouldn't hesitate, you sort of talked about this family network and sort of needing to debrief. I really feel like pastoral, or if you have a religious bent or whatnot, I really feel like I've seen instances where our pastoral care team or our palliative care team, if your own child is facing a serious illness, these kinds of incidents can really bring up a lot of internal emotions that can be it can be important to sort of capitalize on those sorts of resources that are outside the medical setting, but are also, in my mind, sort of part of self-care and self-awareness, to sort of deal with the complex emotions that these sorts of situations bring up, and at least start to give you strategies to not panic. So anyway, I'm sorry. Go ahead.
In regards to code status, actually, our granddaughter coded in the ER, and they took her and worked on her. They rushed her, and so as my daughter and her older daughter were watching this, it was all happening so fast. And there's a little 5-pound baby that coded, and they worked on her for over 7 minutes and didn't give up, and then they brought her back, and then she moved to PQ. So from our status, we already had experience, and she was still with us. And there was another family a couple weeks later, while she was still there, that didn't have as good an
outcome
after. And then our granddaughter acquired hydrocephalus after the fact. So
so just to recognize that that a code status, be it in your family or in someone else's family in close proximity, is trauma, and that it requires sort of spiritual and potentially spiritual, but otherwise certainly self-care, to sort of get over these are truly traumatic events. So I'm just going to put on here trauma and acknowledging that. So I think is important. So any solutions that you have for sort of some of the staff comfort issues?
So here's what we kind of did, because my sister's older. We're older, so we're kind of, we're different on that aspect. When it came time to transition her care, a neurosurgeon was recommended, but we did a little research, and it just wasn't a good fit for her. So what we ended up doing was interviewing a couple neurosurgeons, and it was, all of us were involved, myself, my mother, and my siblings, and my dad.
Oh my goodness.
But the reasoning why was because, we have her medical records, we know her complex needs, and we had interviewed a series. So, we had set up a doctor's visit, and honestly, when you call the office of a transitioning neuro and you explain it, they're gladly willing to meet with you and make you feel comfortable and whatnot. So we did that, and 5 neurosurgeons later, we did that. No, this was just the interview process. I felt like I felt really bad for them, in all honesty. And, when all was said and done and we made the decision, we then set up another appointment of another, quote, interview for the neuro that we had selected to meet the patient. And it was the reason why we had picked him is because he said, when I meet her first, I'm going to take that step back, and I want to see how she's going to interact with you guys in my office. And it was, for a strategy on that aspect, I think it's important that when you transition a pediatric to an adult neuro, you really need to do that research, and don't be afraid to call a doctor and say, hey, this is the situation, and their office manager will gladly set up like a 10-minute and go in with your questions and ask away, and a lot of them are willing to do that.
I hear an incredible degree of self-advocacy in that story. So I love it. What a fabulous suggestion. So do you have any, and we'll come back, this is a theme that I will touch on in a little bit, and do you have any solutions to you talked about sort of having this unique expertise of sort of being the caregiver, and I almost feel like I started to hear a solution in that story,
well,
which was...
What we do is when she's in the hospital, we can be a little tough, just like any parent or grandparent in a situation, and her neuro obviously is a big part of it, so when she comes in, it's the whole situation and everything, and the nursing staff comes in, and one of the things we don't do is talk about it in front of her, because it can be upsetting. But then what we do, because it can, how does a little child feel? Oh, you're talking about me, and yet all of these things, and it can be emotionally upsetting to a child, or even an adult. So what we do is, we kind of just step out in the hallway or even in an empty room if it's available, or the charge nurse's office, and we just sit down, we have a conversation, and we explain all of the complex needs and what's going on. And we also carry everything. We carry a medication list. We carry
I'm going to call it a care plan.
yeah, absolutely.
Oversimplifying.
It's perfect.
Is it like, notebook
yeah,
that
like
thick?
it's a piece of paper.
Okay.
And it's important because you really need to sit down and not be afraid to talk to the floor staff, because they're taking care of not only the patient, but you in a way. I mean, sometimes when you're overnight and you need a cup of coffee, they're going to provide it to you.
Sure.
And you got to we talk to them, and, and what we've come up with, and this is lots of years of this, is they're like, okay, well, what can we do? And we give them those options, and then we kind of develop a plan together, and then go from there. So you kind of have to not be afraid to talk to those nurses. And if there's a nurse, and sometimes there is, that you feel isn't necessarily understanding, don't be afraid to talk to the charge nurse and say, this is the experience that I'm having. Maybe I'm upset, but can you guide me? And it helps.
Sure. That's wonderful. So I put up here sort of care plan at the risk of oversimplifying years of knowledge, but we heard a little bit about this earlier about journaling, and it's sort of that same notion of putting everything in one place and having a handy reference, and then really engaging staff, like it sounds like, and sort of being an advocate. So, okay. This was awesome. Thank you guys so much. I'm going to move through some prepared comments that I put together, and I hope it will resonate with you, because I really feel like I heard some common themes that resonate with my experience and with some of the reading that I did. So I feel like I don't know that this is entirely true, because I wasn't really quite sure what you guys were going to come up with in terms of challenges, but I feel like what I've observed is a lot of, when I see primarily caregivers sort of having a hard time, it's often around uncertainty. Early in stages, uncertainty around diagnosis, so there's that painful period of what's going on with my child and why are we here. Then there's sort of this progression into treatment and sort of what's going to be happening. And then this question about sort of how will things happen, and what the hospital is a strange and foreign land. So how are things going to happen here? So I think that probably I'll have to change the slide after hearing what you guys have to say, because it's much more complex than just this. But I do feel like some of what you had to say really speaks to some of what I'm going to walk you through in terms of stages in patient and family experiences, as well as family and system interactions. And I want to just take a moment to say it's a real privilege to be a little bit further along in my career and have mentees, such as this wonderful mentee I have named Carolyn Shook, who brought this particular report to my attention. She brought it to my attention a couple of years ago, and it really crystallized my understanding of children with medical complexity and sort of what their patients and families are experiencing. So the Lucille Packard Foundation funded a sociologist or an ethnographer to go speak with 8 families of children with medical complexity about their experience of caring for their child. And I think you're going to see a lot of themes that we've talked about here. So there's in the first stage, so basically this report came up with several different models, and I'm going to walk you through some of those models, because again, they really resonated for me. So starting with sort of the pre-diagnosis phase, this report argues that you move into sort of a crisis or diagnosis and treatment phase, and then you re-enter into what's called like a new normal. And this is sort of some of your maintenance and complications. And then you hit, as you've alluded to, the age 18, and sort of what sadly it's really discouraging, they term the transition wall, but sort of the experiences that families have as their kids get older. So in the first stage 1 pre-diagnosis, this is where the family is realizing that the child is ill, but there's no specific diagnosis that's been made, and this can generate a whole lot of fear and anxiety. I'm sure you've all vaguely remember back in the past that experience. And here, I often certainly feel like this is true. Parents get really frustrated by the uncertainties, and they think that things should be happening a whole lot faster than they are. So I'm assuming none of you are necessarily or few of you are in this stage since you're here at the Hydrocephalus Association meeting. So it sounds like you've got a diagnosis, but this is very true. I think it's very true. I had the experience of my dad had a stroke about 6 or 7 weeks ago, and I certainly had this experience of trying to advocate from 3,000 miles away for him to get a head CT, and I sort of was like, I kind of feel like I've just been there. So not to say that you can't re-experience it. So in stage 2, you sort of get your diagnosis and treatment begins, often in the hospital setting, and a lot of parents will sort of get, at least according to this ethnographer, sort of a form of tunnel vision, and they become very focused on their kid and what's going on with the treatment, and that can be to the detriment of all the other parts of their lives, their other children, their relationships between themselves, their jobs. So that's sort of a rocky time. And then there's, after the initial immediate health crisis is over, you sort of are returning to the community. And this is an interesting time. This was sort of a light bulb for me that went off, was that a lot of this, the hospitals actually, ironically, are resource intensive. There's a lot of available resources. And then you go out into the community, and it's a struggle to sort of get what you need and establish a new system of care and adapt to your new life. So the whole context of people's lives has changed. The challenge is to get connected to available resources, and this is one where a lot of people have alluded to this, but you need a whole lot of cooperation from your other family members. So this is where you start really needing to get your willing, able, and available network. And then you move into stage 4, the new normal. So this is sort of a time of time of high stress on relationships with family members and others close to them. They basically are no longer focused necessarily entirely around the child with special needs. Families might experience some mourning for the loss of their healthy child, and then there's this sort of up and down period with lots of setbacks, or recurrences, or complications. So you can kind of be cycling in and out, and that can present its own challenges. And then your kid starts getting older. They are becoming teenagers themselves, so they start to develop their own expectations about what their life is going to look like. And you guys have to broach a whole new system of sort of potentially lack of services being available, but it's really hard to prepare for this unknown. And then, I hate to say this, but there's this transition wall where you sort of have, at least these families refer to hitting the wall, where they're really struggling to sort of come up with resources. So again, this is the model, and what I thought was kind of cool was that they describe this red line as sort of being what a kid might need, and then this blue line is sort of what you're able to get. So you can kind of see there's always a gap between what you need and what you can get, but it fluctuates over time. And that was kind of a helpful thing for me to think about, specifically because I'm working in the hospital setting, and I can sort of pick up the phone and call my social worker, and now I know I can call my outpatient pharmacy if a parent needs medications. I can call our pastoral care services. So I know that I've sort of developed tunnel vision around my experience of being here. But oh my goodness, when a kid leaves the hospital and needs to go back home and is out in the community, this is what folks are experiencing, is this big gap between what they need and what they can get. And so this mismatch between needs and resources, it's especially true at the time of discharge from the hospital and then at the time of transition from pediatric to adult care. So there's lots of families with lots of stories about huge lengths that they need to go to, not the least of which is interviewing 5 different neurosurgeons before landing on one. So the other concept that this report speaks to, which I found really helpful, again, for me was an aha moment, was that there's sort of this notion of system friction. And the more urgent a need is, the less friction that you sort of encounter. So you had the example, so you come into the ER with sort of nausea, vomiting, diarrhea, and you have hydrocephalus. You're going to get all kinds of things that you need, sort of pretty quickly. And I, again, work in the inpatient actually your PICU is sort of, again, a resource-intense kind of situation. But again, as you sort of leave the inpatient setting and you go out into the community, it's harder and harder and harder to get things that you need. So my son has special needs and requires speech therapy, and I can't tell you how much time I spend at the school beating my head against the wall trying to sort of get speech therapy for him. So anyway, so basically, this report is appropriately arguing the healthcare system needs to be adjusted so that there's adequate access to appropriate resources at all levels of acuity. But for me, this model really speaks to the imperfect world that we actually live in. So, and again, for me, it was sort of an aha moment that it's like, oh, no wonder I like to work in the hospital setting, because I can pick up the phone and call so many more resources than I would if I were an outpatient provider. So it's a little bit about sort of the life cycle of sort of the experience of kids with chronic illness, and then sort of this gap between needs and resources. So the other thing that has already been alluded to in this room, I love it, is sort of the range of experiences between the family and the system. So, and the way that this model sort of put or classified families is vulnerable, compliant, advocates, and activists. So the vulnerable family may be limited by or incapacitated by cultural, psychological conditions. The compliant family is doing what they're being told to do, but isn't asking a whole lot of additional questions. The advocate is sort of starting to make those connections, talk with the charge nurse when they need to, using their relationships to obtain additional resources. And then you've got the activists. I would argue you all are at a Hydrocephalus Association meeting. I'm going to put a lot of you in that activist category. So where you sort of see yourself as an active part of the healthcare system. The team, you're going to eventually be using your expertise to help others, and you all have already done so because you're sitting in here today coming up with strategies for others. So, and this, again, this report makes an argument that as a family progresses, if this is a spectrum, the more activists they become, the more resources they get. This report goes on to argue you shouldn't need to, like when you were like me and my dad had a stroke and I was in the compliant, we're going to do whatever the doctor says sort of phase, you should still be able to access the same amount of resources. Again, in our imperfect world, that's not actually what we observe. So the reason this matters is that this is, again, another model in this report. There's this notion of, again, in our imperfect world, our families and caregivers become the care coordinators for these kids. And you only know, this horizon is sort of the services that you're aware of. And so you may or may not, in the throes of taking care of your kid, you might know like about your insurance, for instance, and about what's going on at your kid's school, but you might not know about all these other possibilities out here. So there's sort of you only know what you know. You don't know what you don't know. So, so this particular report is sort of advocating that we really need care coordination. So who these people are is very much a topic of national debate, but the idea is that there should be expertise where care coordinators are able to sort of network beyond the parent's horizon and sort of get folks resources, additional resources that they might not be aware of. So a lot of my professional career lately has been focused on developing quality measures to get care coordination to children with medical complexities. So just wanted to talk a little bit. These were my thoughts about strategies to overcome strategies. So I just wanted to urge you guys to think about recognizing that the challenges that you're experiencing might be specific to the stage of you and your family's experience with hydrocephalus. I sort of feel like we've got folks in the room who have experienced transition. We've got folks who are sort of in adolescence. So there's sort of that recognizing that these challenges that you're going to have not only in and out of the hospital really do depend on where you are on that spectrum. I would encourage you, as a hospitalist, I'd like to believe that hospital stays are an opportunity to move, like if you're in a vulnerable or a compliant state. These are opportunities to ask questions and sort of become more of an advocate and eventually, hopefully, an activist for your child. I also think that, again, hospital stays, I'd love to advocate for hospital stays being an opportunity to coordinate care. So you've got access to all kinds of folks that you might not otherwise. So I heard a little bit of you talking about your PICU experience and asking lots of questions, and I really want to come back to that. I really think that, sort of in a collegial, engaging way, use this captive time to sort of figure out what else is out there and sort of see if there's more that can be done, because there probably is. So I don't want to underplay the risk that's associated with coming into the hospital and leaving the hospital. I didn't talk a whole lot about it, but these are risky times. And I love the notion of journaling and sort of documenting things and these care plans as tools. Once again, some of my mentees are spending their academic careers sort of working on trying to optimize these tools. So I'm hoping we'll have a whole lot more in this area in the future with your guys' input that will sort of advance things for many children with medical complexity. So not just kids with hydrocephalus. I'd like to take a moment to thank children and their families for everything that you all have taught me and this new little pearl, for instance, about the outpatient pharmacy. Thank you for that. And I'd like to take a moment to thank the folks who have funded my career, and my mentors and now mentees, as well as my own family. And I really appreciate your attention and engagement. So it's really been a pleasure. So.